Colleen's going to record. Brian, I think we'll get started. Brian. Oh my God, you mess this up every time. Okay. Okay, that was not nearly as dramatic as I wanted it to be. I don't know why. Brian, you're fired from sound from now on. Like every time we try to do sound with Brian, it doesn't work. So I was just playing it on my phone earlier and it worked perfect. So anyway, hopefully you all heard a little tiny bit of the Olympic rendition, which is called Olympic Fanfare. So welcome to our Science Slam today, the Mass General Research Institute Science Slam, co-sponsoring with the Women's Sports Medicine Program. And we're really excited that you all chose to spend an hour with us here at the end of your day, middle of your day, depending on how late your day is going to go. The Research Institute, we started doing these Science Slams. When we started, of course, we were in person at Beerworks. So this is not as good, but it's actually our virtual slams have turned out to be pretty good. We did 5 in-person science slams, and since COVID, we've done 5 virtual science slams, and I've been surprised at the success of the virtual. So it's a fun way to spend a little time and hear a little bit about science. The goal, of course, is for our people who have chosen to share their science, is to be able to explain your science in 3 minutes or less, in a way that you would explain to lay people, right? This is a skill that scientists struggle with. I'm sure many of you know scientists that struggle with this. And it's really, really important that we're able to explain the science that we do in a way that the general population can understand, because we need to continue to build support for science. And if they don't understand what we're trying to do, then they close their ears and they don't listen to what we're doing. So our co-sponsor today, as I mentioned, is the Women's Sports Medicine Program, and Dr. Miho Tanaka, who's the director, is here.
Right here at 9C. She'll be right back.
Okay. So Miho, I think that was not for us. Okay. There. Okay. Miho, maybe you want to say a few words about the program, and then we'll go ahead and get started.
Sure. Yeah. Thanks so much for this opportunity. I think on the call, we have a couple key players from the Women's Sports Medicine Program. I see Stephanie Seminara, and I see Miriam Bradella. And so they're waving now. Right. And so this program, is something that's been going on now for a couple years, and it's really designed to fill clinical gaps. So instead of looking at problems related to the female athlete through one specific discipline, we have 11 different divisions and 26 people who come together to really put our heads together to solve clinical problems and to address research in a multidisciplinary manner, and then to take that information and to share that with our patients. So some of the projects that you'll hear about today, I think, will be related to that. Some I think are maybe just on sports medicine, but that's kind of the goal of what we've been working on our side. Miriam or Stephanie, do you have any words to add?
Just that I think the sports medicine program is interdisciplinary. It's great. I'm an endocrinologist, and I love the fact that I can be part of the group that's led by Miho. We bring, thoughts about how sometimes negative energy balance can affect very superb athletes and have reproductive endocrine repercussions. So I love that Miho has built something that's interdisciplinary that brings so many different faces around the table. And I'm really thrilled to be part of it.
I'm super excited to be here as a radiologist, and we have, the mentor of our radiology representative, Joao Tenera, is actually a woman, Connie Chang, who will also join here to cheer him up, and we are very excited to be here today.
Great. Well, thank you for agreeing to co-sponsor the Science Slam. It's always great when we can get someone to help us recruit people to listen. And then we love having people who just want to learn a little bit about the science. So with that, we'll go ahead and get started. So where's Meg? Meg is right there. Wave, Meg. So Meg is the timer. Okay, so it's really helpful. What?
I'll show them what it'll look like.
Yeah, so she'll show you what it'll look like. So for those. So I think for the people who are slamming, it's a good idea to keep your screens on. I hope everyone will use their reactions as they're talking. And that the goal is to not, obviously thumbs up if they're doing a good job. Now it seems we have every emoji under the sun in our reactions button. So thumbs up, they're doing a good job. If you don't understand, there's probably a question mark in there. If they say something that you don't necessarily understand, like the idea is to be able to give them feedback. So for you guys, it's probably beneficial for the slammers to have it on where you could see everybody, so you could see if there's any reactions. For the rest of you, it's up to you if you like to look at everybody and see the reactions, or if you want to put it on speaker mode such that you can just see the speaker. But please use the reactions and give some feedback. And Meg will start the timer. Did you show what it'll be? Okay, so everybody can see the timer. So our first team who asked to go first is a team presentation, right? And so they're from the Reproductive Endocrine Unit. So it's Shreya Jadhav. I apologize if I'm not saying your names right. Shreya, Soren Kernan, and Mark Campbell. And that's the group of 3 in masks down there. I could see them. And so we're really looking forward to your presentation. So Meg, you
all right. Is everyone able to hear me all right?
Perfect.
Okay, in that case, I'll get started. Hi, everyone. My name is Soren, and today my colleagues and I will be talking about the reproductive axis and one form of its dysfunction called hypothalamic amenorrhea, or HA for short. So to start off, what is the reproductive axis? It's part of our hormone system. And when the reproductive axis communicates normally, ovulation occurs in women and sperm is produced in men. The reproductive axis is driven by several hormones, including one called kisspeptin. The release of kisspeptin in the brain causes the release of GnRH, gonadotropin releasing hormone. And when gonadotropin releasing hormone is released, that in turn causes the release of luteinizing hormone and follicle stimulating hormone. In women, different levels of LH and FSH provide cues to your body to move through the different phases of the menstrual cycle, like when it's time for the ovary to release an egg. So normal function of the reproductive axis is very important for menstruation and therefore for fertility and pregnancy. But what about when the system is disrupted? A condition called hypothalamic amenorrhea occurs when low levels of GnRH in the brain prevent menstruation. Now, low GnRH consequently causes low levels of other hormones in the reproductive axis. HA is most common in young women who exercise a lot or under lots of psychological stress. Not getting your period every month may sound great to some, but women with HA also face higher risks for cardiovascular disease and poor bone health. We suspect that giving extra kisspeptin may help women with HA by assisting them in regaining their LH pulses. Our group will recruit women with HA and use a kisspeptin pump to mimic what happens in the brain. Ultrasound imaging will show whether the kisspeptin pump allows women with HA to produce mature follicles in the ovaries, which is a critical step in egg release that is disrupted in HA.
As Shreya mentioned, we will be recruiting women who have been clinically diagnosed with HA. Participants will wear a pump for 14 days that releases kisspeptin under the skin in a pulsatile fashion, which is similar to what happens during the beginning of the menstrual cycle. We will also collect blood samples and conduct ultrasound imaging during those 2 weeks. These data will help characterize hormone levels and follicle development in participants. We hope to see the development of a mature follicle in women with HA who wear the kisspeptin pump, which would indicate that kisspeptin restored normal functioning of the reproductive axis. As a result of this research, kisspeptin could become a treatment for HA, hyperprolactinemia, and other reproductive disorders. Thank you.
Excellent job. Okay, excellent job. Excellent team effort. We love to see the team today. Great job. Very understandable. Does everyone agree? Looks like you got a lot of thumbs up. You could also like thumbs up everybody, you know. And of course, Stephanie's super proud of this team. Of course she is. So that was great, guys. Thank you so much. We really appreciate it. Okay, so let's go on to our next presenter. I don't know where you are, so you're gonna have to wave at me. João Vincentini. Do I see?
Hello, can you guys hear me?
Oh, right, perfect.
All right.
Okay, am I saying your name right, João?
João, yeah.
João, okay. Is from musculoskeletal imaging and intervention in the Department of Radiology.
Yeah.
Take it away.
All right. Whether you're an athlete or not, chances are you know someone or you yourself have been dealing with chronic back pain or joint pain. And if that's the case, you've probably heard of steroid injections, or also known as cortisone shots. Cortisone is one of the many types of steroids, and they can have many uses, one of which is treating pain. The way steroids do that is by fighting inflammation in different parts of our body. And we as radiologists can use X-rays or ultrasound to guide us and show exactly where we need to inject, so we can inject where we think will help the most. Steroids can be very helpful, but as any medication, it's not free of risks. When injected in large amounts, we know that steroids can affect our immune system and our ability to fight viral infections or any other infections. In a normal situation, we know the amount of steroids we inject is safe. But what happens when we have a worldwide infection that we know very little about? So yeah, COVID brought a lot of changes to our lives in 2020. So our group here at the Musculoskeletal Imaging Division decided to follow patients receiving steroid injections with us. And we checked on them a few weeks later to see if there were any symptoms or any diagnosis of COVID-19 during that year. We followed more than 1,000 patients for almost a year. And this was before vaccines were available. And I'm happy to share the good news that we did not see an increased risk of COVID-19 in this group. Although we're very happy with these results, we know there are always changes happening, new variants and new developments. So our research is ongoing, and we'll keep an eye out for new projects and new opportunities, so we make sure we can offer safe procedures for everyone. So you can go out there and, try to be a pro, or if you prefer, just stay comfortable at home and make sure you're feeling well so you can watch other people try it.
Excellent use of props. I like the helmet at the end. Try to be a pro. I'm sure there's a lot of what do you refer to them as, in like weekend athletes, or something like that, where everybody gets hurt all the time doing something only on the weekends. Great. It was really interesting, and again, I think really understandable to lay people. I think it's very clear right? Everybody gives a big thumbs up there. Awesome. Thank you, Joe. Okay, our next presenter is Garrett Kearney. Where's Garrett? There's Garrett. We'll give Garrett a big hello today. Garrett is an undergrad. Garrett, maybe you could tell us where you're in school. And he works with the orthopedics department in Foxborough doing research as an undergrad. So Garrett, welcome and thanks for joining us today.
Great, thank you. Hello, everyone. So today I'll be discussing a research project that Max and I actually have both been working on, focusing on ipsilateral or same side ACL reconstruction. And we just want to talk about some of the data points we saw. So whether it's Brad Marchand coming in to slew foot you from behind.
Garrett, I'm sorry to interrupt you, but it's a little hard to hear you. Can you come a little closer to the microphone?
Yeah, sorry. My bad.
Okay.
So whether it's Brad Marchand coming in to slew foot you, or if you decide to all of a sudden, catch an edge on a snowboard like this one here, or if you are up at 5 a.m. to take your kid to hockey practice and you slip and fall on some stairs as you go down, well, those all can lead to an ACL tear. So, however, this is really difficult because you go through surgery and then you go through physical therapy. It's like climbing up, the hill with the cross-country skis. You're finally at that point where you're going to be done and over with and at a pre-injury status. But then all of a sudden you could be like Lindsay Jacob Ellis, where you see the distance in sight and all of a sudden you fall flat on your face and it doesn't work out and you need to go again for a second surgery.
Oh, sorry.
Either way, this leads us to focus on whether time between surgery and, first and second surgery could possibly be an important, issue. Additionally, we looked at different cartilage and chondral defects, specifically within the lateral or the far side versus the medial or the inner side of the joint, and the patellofemoral compartment to see whether or not there's, injuries or increase in injuries between the first and second surgery. So we looked at our patient pool through EPIC, which we all adore so much, and we got 204 total patients. While examining this, we did not see any real change in chondral defects based on just time of surgery alone. However, we had some very interesting results. When we examined overall all of the chondral compartments, we just saw that there was about 2 to 3 times as likely of a chance of getting a chondral defect in the second surgery or second injury compared to the first one. And within the female compartment specifically, we saw that women were about 5.6 times as likely of getting a chondral defect in the lateral femoral condyle compared to their first surgery. And additionally, with males, we saw similar results with the medial femoral condyle. We did not see anything really with the meniscus, which was very interesting because we would have thought there would have maybe been more stability issues after the second surgery. But there was nothing to really talk about there. But in the end, this is very important because it's like shooting in the biathlon. You usually have 3 to 4 times to basically repair your ACL before you have to go through other possible treatment options. So thank you very much for your time.
Excellent. I admit to missing one or two of the things that you were saying. I got the meniscus, but the other, the names of the tendons or whatever, I think, right. So, and Garrett, where did you go to school?
Johns Hopkins University.
Awesome. Well, thanks for sharing today. You get the prize today for the best use of real athletes to illustrate your what you're trying to talk about. So that was awesome. That was really great. Thank you. Okay, our next presenter is Junfeng Wang, who's a research fellow in radiology. Are you here, Junfeng? Do you see them, Colleen? Is somebody waving and I'm missing them?
No, I didn't, and I don't see their name here. So
you don't see the name?
No.
Okay, well, maybe they'll join us. Keep watching and see if they join late. Okay. All right, so we're gonna go on to Michael Galletta. Is Michael here?
Right here.
Perfect. Hello, Michael.
Hi, how are you? It's great
Good.
to be here. Thank you so much for the opportunity. All right. So, hello everyone. My name is Michael Galletta. I'm here representing the Sports Medicine Service. I want to talk to you guys about the shoulder, the rotator cuff, and some artificial intelligence. So, when we talk about the shoulder, we typically use the analogy of a golf ball on a golf tee pretty regularly to illustrate how it's a ball and socket joint, but the socket itself is actually much smaller than the actual ball. And what's really interesting about the shoulder too is that T is on its side. So you can imagine how unstable that shoulder is without any kinds of restraints keeping it in place. So what we have is this combination of muscles that actually wrap around the shoulder and pull it into that socket to keep it nice and contained. That's our rotator cuff, okay? And that rotator cuff, it consists of about 4 different muscles. So if we're looking in from the side of our shoulder here, we have 1 in the front, we've got 1 on top, and then we have 2 on the side right here. Now, sometimes these muscles can tear. They can rip off and they can retract. So typically we go in there if the patient's young enough and we repair it with surgery. But what happens when that is not the case? What happens if we can't do that? Specifically, if those tears have been left alone for a long time, the tissue quality can change for the worse. So if this is our normal rotator cuff, it's very contractile, right? And it looks very homogeneous. The tissue quality looks very nice. If we leave that quality alone for, say, a couple of years, that quality can actually be pretty difficult to manage. And the risk of that tearing out if we went in with surgery is elevated. So we need to be very smart about who we choose to operate on. Now, what we are caring about is fatty infiltration. So the composition of the actual muscle belly of good, healthy muscle fibers versus fatty fibers. So if you guys have ever been to a butcher shop, you know that there's steak and there's different levels of marbling on that steak, right? So over here on the right, you can see one that's a little bit more healthy, that's got more of those muscle fibers. And as we keep going on, we can actually get to a point where there's more fat than healthy tissue, which is definitely not where we want to be with our rotator cuff. So with artificial intelligence, our amazing colleagues at radiology have figured out a way to segment out and trace the outline of these muscle bellies. And then further, they can segment out the fat versus the healthy tissue. And why that's important is we want to be able to make claims that say, with every 10% of fatty infiltration, the risk of failure in surgery goes up 2 times, 3 times, something like that. And so obviously we want to think that the more fatty infiltration, the worse off we're going to be. The cool thing about the AI is that it can segment in a fraction of a second compared to maybe 30 minutes for a human. So this really increases the efficiency of what we're able to do, and we're very thankful for that tool. So yeah, thank you so much.
Excellent job, very clear. Love the pictures. The raw steak made Stephanie hungry thinking about the shoulder.
Yeah.
I think we all, well, if you get to my age, then you've felt every one of those muscles in your shoulders. I don't know, maybe some of you younger people haven't felt them yet, but I think it's a very common problem, right?
Absolutely. Thank you.
So then we'll know going forward, this is going to be able to tell us whether surgery will be successful or not, right? If you go in.
That's the idea, yes.
Awesome. Okay, our next presenter, unless Jun Feng showed up. Nope, I guess they're not going to show up.
I just sent a quick email.
Okay, good. Soleil? Soleil, is that how you say the name? Soleil Ashkani.
I also did not see on here.
Okay.
Weird. Okay, I will also send an email over there.
Okay. Okay, and all right, we're going to go on to Maxwell McKay, who's also an undergrad in orthopedics in Foxborough. Is Maxwell on?
Hi,
there
everybody.
he is. Okay, awesome. Hi, Max. I see you go by Max. Okay, Max, go.
All right. Today, I'm skating into this Olympic-sized virtual science slam. Funny enough, my journey starts with ice hockey. 2 contralateral shoulder injuries derailed my hockey career, and my physician told me that I could no longer participate in high-level competitive sports, a prognosis that dramatically altered my life path. The impact of this event propelled my interest in orthopedics, specifically orthopedic research, where my goal is to identify the genesis of musculoskeletal injuries in athletes and ensure what happened to me does not happen to them. To accomplish this goal, the work that I've done with the orthopedic department at MGH with patient data collection and analysis aided in the methodology of future projects. One project uses artificial intelligence to analyze neuronal networks associated with muscle atrophy and fatty infiltration seen on MRI imaging of the shoulder in patients with rotator cuff tears. Another project involved 3D computational modeling and laboratory testing to investigate the high velocity motion and biomechanics of baseball pitchers' shoulders and elbows. More recently, I have turned my focus to the most injured joint in sports, the knee compartment, more specifically, contralateral anterior cruciate ligament reconstruction. The goal is analyzing chondral structures with defects in their relationship to gender for contralateral ACL reconstructions. If you could all please direct your attention to Garrett Kearney's virtual box for a diagram. The structures in the knee that were analyzed include the patella, trochlea, medial femoral condyle, medial tibial plateau, medial meniscus, lateral femoral condyle, lateral tibial plateau, and lateral meniscus. Patients who underwent ACL reconstruction on both knees at the institution were identified. I performed a retrospective review to obtain dates of surgery, demographics, and clinical data from the operative reports in the EPIC database. In each compartment, I recorded the outer bridge grade of the cartilage defect, as well as the presence and location of meniscal injury. Crafting patient databases, extracting relevant patient data, and statistical analysis and quantification of large amounts of information and resources were all required. From the data analysis, I was able to find that there was a relationship between the rate of chondral defects and tearing in the lateral compartment and gender, where the lateral femoral condyle, lateral tibia plateau, and lateral meniscus all showed significance within the available data in the patient pool that may support the assertion that males are significantly more likely than females to have a chondral defect or meniscus tear in the lateral compartment of the knee joint intraoperatively during the contralateral ACL reconstruction. When I reflect on my journey so far, I couldn't imagine not being a part of a field that helps people like myself. I want to ease the burden of someone's suffering because it's not only gratifying, but it is a privilege to facilitate the process of healing for somebody. I love my position as a research intern because it will give me the confidence in my abilities that I need to execute my motivations and continue the path to becoming a professional researcher in orthopedics. Thank you very much.
Awesome, awesome. Okay, so we have 2 future professional researchers in orthopedics, it sounds like, or physicians and physician investigators in orthopedics. That's awesome. I saw one person wrote in the chat, the most creative way to circumvent the ban on PowerPoint slides for the Science Slam. When we were in person once, we, and you just get up in front of people, with a microphone and talk about your science. And, a few props here or there. Someone literally brought once PowerPoint slides printed out on pieces of paper, and they were holding them up, and they started, and I went up and took all the piece of paper away. And I was like, okay, you cannot do this. You have to tell us about your science without using the pieces of paper. So, but good visual. Believe me, I needed it. I needed the visual. So that was great. Okay, our next presenter is Neymar Power. I'm sorry if I said your name wrong.
Hi all, that's okay. I'm gonna just have my colleague help me with the presentation.
Okay, wait, I don't see you. I have to find you. Hold on. Wave to me. Oh, perfect. Great. Okay, I gotcha. Okay, Neymar, I should say, is from the neuroendocrine unit, and she has help from a colleague. So take it away.
Yeah. So do I start? What's my cue?
Go ahead.
I'm sorry, I realized I had muted before I said go ahead. Go ahead.
Okay, I'm gonna start. Okay. Hi all. Meet John Doe, a 23-year-old track runner who wakes up at 5 a.m. to work out, eats dry fruits, is basically super fit, and drinks lots of water. One evening while he was running out, he felt a sharp pain in his lower leg and couldn't figure out why. Even his orthopedic surgeons couldn't wrap their head around the cause of fracture that showed up on his x-ray. But don't worry, John. Here comes a team of endocrinologists working on the science of stress fractures. But before we dive in, let me take you on a journey to the very beginnings of this mystery. A long, long time ago, almost 20 years ago, scientists were trying to figure out why a fair number of women lost their periods. Several science experiments later, the field has progressed leaps and bounds. Researchers concluded that a state of low energy availability led to a loss of periods, which in turn led to a loss of bone health. That is what constitutes the female athlete triad, the all-star lineup of bad news. The low energy availability leading to a suppression of the signal from the brain, hormone signal from the brain to our genital organs, which in turn leads to an impaired bone health. Now I know what you're thinking, but what about John? Our team's agenda is to figure out if such associations are found in male athletes. We study men aged 16 to 30 years of age who run more than 30 miles a week and compare their energy availability, their blood hormone levels, and their bone health to men who do not run. It is that simple. Our early data suggests that male runners have lower bone density in the tibia or the shin bone. To make it simple, tibia is the stronger of the two bones in the lower leg. The cortex, which is the outer shell of the bone, was shown to have lower bone mineral density, a contributor to bone strength. We also found out that athletes with a lower body mass index, a proxy for energy deficit, had lower bone strength, tibial bone strength, than those with a higher BMI. Also, athletes with a lower lean mass, indicator of the muscle mass, and lower hormones made by the regulated by the fat cells in the body, like estradiol and leptin, also had lower tibial bone strength. So we are working to determine if there are other factors that are contributing to this process. So don't worry, John. Do not worry at all. We've got your back. We at this lab are trying to help all the athletes, all the Jacobs, Jasons, Javeds, and Jaspreets on the field. We are giving our best in the lab so that they can give their best in the field. So go break a leg, but not really. Thank you.
Excellent, excellent, excellent. Great job. That was so good. That was so good. I see several people putting in the chat. It's a great way to learn about science. And that's really why we started this, right? It's really great to listen to short snippets of the science, to learn a little bit about what's going on across MGH. We do this in bite-sized nuggets, so it's not too much, but just getting a view of, of what's going on and to hear about this research is really, really great. So did either of our other people who signed up, Colleen, join?
Jun Feng is here.
Good. Jun Feng, we're thrilled to have you. Where are you? Wave at me.
He's on his phone, so he's.
Okay.
He's a rectangle.
Yeah, sorry, I just erupted. Yeah, I just got here and I forgot, and I'm using my phone in the lab.
Oh, okay, great. So this is authentic and real, right? You're in the lab.
Yeah.
Okay. All right, Jun Feng, take it away.
I will do that next time.
Oh,
It seems like he's not able to do it.
You'll be our number one next time we do one of these. Is that what you're saying?
Okay.
Instead of presenting now.
Oh, okay. I'm sorry. I thought you were going to just do it off the cuff.
Nope.
That's totally fine. Okay. All right. So while I have everybody, thanks, Jun Feng. We will remember that, and we will come back to you for our next Science Slam.
I know.
And Soleil, did they join?
No.
Okay. All right. So I always open the floor. If anyone else has been inspired, you don't need props, but to spend just a couple minutes telling the group about the science that you're doing, you're more than welcome to take the floor. This is, believe it or not, this is how we started. So now we ask people to sign up just so we know that we have slammers. But when we did it at the bar, you would be amazed. The later the evening went, and people would have one beer, and then after 2 beers, they were much more likely to share their science. And then we were much more likely to have to drag them off the stage, because they're typical scientists, right? As soon as they start talking about their science, they get so excited, they went way over the 3 minutes. So we would drag them off the stage. So this is the one thing that's a little different about having this be virtual.
It's Miho. Sorry, I am not going to present anything, but I just wanted to mention that at the beginning of the call, when I introduced the other women's sports medicine program members, Madhu Misra was on, but I didn't see her and I feel terrible. So I just wanted to also introduce her, because I think some of these projects are, her mentees, and see if she wanted to just contribute a few words also. If that's okay.
Absolutely. Madhu, where are you?
I'm here.
Nice
this is terrific. I'm just so impressed with the presentations and all the ideas. I don't think I would ever have the creativity to do what you guys have done. So kudos to you. Congratulations.
Thanks, Madhu. Yeah, it's really, we get some really creative people. And, again, what the message that I hope you all take away from today is how important it is to be able to talk about the science that you do, no matter how complicated, but in a way that everyone can understand. And we do get people joining these who are not scientists, who, you know, love learning about this. We've had donors join in the past. And so I think it's a really important to figure out like how to explain what you do every day to scientists. And yeah, Meg's right. Every time we do it, people find new ways to present their science. And
it looks like we do have Cora listening. So if you can explain it to.
Exactly. If you could get Cora to understand.
She 4.
Yeah, exactly. So we're that's all we have today, but I really want to thank you for joining. I think I'm going to handle the music. Can you hear? Okay. Thank you all for joining us today. It was really great. And on behalf of the Mass General Research Institute and the Women's Sports Medicine Program, we love learning about some of the science that's going on out there. And I hope that you'll keep your eyes open for the next slam. It could be on any, we welcome slammers on any topic, regardless of who is co-sponsoring. So if you just listened today and you want to present your science anytime, please join us at the next slam. Yep. Okay. Have a great afternoon, everyone.
Right.
Thanks for joining us.
Bye.